Hello friends, a very good evening to all of you. So here we are today with 100 most important or very important essential one-liners from pediatrics for you. So this session is going to be a very quick revision of some very important 100 facts that we must know for your upcoming exams. Okay. So I'm going to keep this session really crisp and short so that you because your exams are fast approaching and the time is very limited, so we will really keep it very crisp and quick and to the point. And these are some 100 essential things that you must know, and of course the topics around it are very important. Okay, and once you get familiar with them, any questions that you get from these topics or around these, it becomes very easy for you to answer them, right? So let's begin. So the first one, the most common cause of short stature during childhood is, so we all know it is constitutional delay in growth and puberty. What happens in constitutional delay in growth and puberty? So during childhood, the child has short stature, but the ultimate final height attained in this child is going to be normal. So it is just a delay, okay, in growth and puberty. But in adulthood, there will be no short stature here, right? And you will get a history of delayed puberty in these individuals. You can get a family history of delayed puberty as well. And in these children, if you're going to do bone age, okay, the bone age is going to be less than the chronological age. Okay. So friends, I am not keeping this as a question answer session. This will just be a very important and quick revision of very important 100 things from pediatrics so that you can revise it once more before your exams, okay, in a high speed, right? So bone age less than chronological age we know is seen in constitutional delay in growth and puberty. Some other important causes can be like growth hormone deficiency, where you will get bone age less than the chronological age, but the upper segment lower segment ratio is going to remain normal because these are causes of proportionate short stature, right? Point number 2, microcephaly or small head. The definition is very important. It is defined as head circumference less than minus 3 Z score of expected according to age and sex. So most of the parameters, we tell it abnormal if it is less than minus 2 Z scores, right? Like short stature is defined as height of a child less than minus 2 Z score of expected. But microcephaly is a parameter where, head circumference less than minus 3 Z score of expected is microcephaly. While macrocephaly, if you ask me, macrocephaly is head circumference more than plus 2 Z score of expected, okay, and not plus 3, right? An important cause of microcephaly, we know they can be primary or genetic causes like, Cry-Du-Chat syndrome, Cornelia de Lange syndrome, Edward syndrome, Patau syndrome. There can be some maternal causes like maternal alcohol intake, maternal radiation exposure, phenylketonuria, and so on. And there can be some causes related to the baby as well, right? Now moving ahead to the next third point. So craniosynostosis. What do you mean by craniosynostosis? So craniosynostosis refers to abnormal head shape due to premature fusion of cranial sutures. Okay. So if any cranial suture gets fused prematurely, then you know what happens? The shape of head becomes abnormal because growth will happen perpendicular, okay, to that, right? So, craniosynostosis, can you have, I'm sure all of you know what are some syndromes associated with craniosynostosis, has been asked your NEET PG pattern question previously. So, some syndromes associated with craniosynostosis are like, yes, waiting for your answers. So, craniosynostosis syndromes associated with it, some examples, at least the names you should be familiar with are like Carpenter syndrome, okay, Pfeiffer syndrome, Carpenter syndrome, Pfeiffer syndrome, Eppert syndrome, okay, and Krausen syndrome. Krausen syndrome. So these are some of the syndromes associated with craniosynostosis, right? There's something called plagiocephaly also. Plagiocephaly, on the other hand, is not so abnormal. It is basically due to deformation or lying in one particular posture for a very long time and persistently, right? So moving ahead. So very good. I can see some of you already answering craniosynostosis. Very good. Now, achondroplasia. What happens in achondroplasia? What is the mode of inheritance of achondroplasia? Yes, very important. One liner has come n number of times. So we all know the mode of inheritance of achondroplasia is autosomal dominant. And there is a large head with short limbs. There is mainly the proximal shortening of the limbs is there. Trident hand. So hands are like this. Fingers are oblique to each other. Trident hand and champagne glass pelvis is also there, right? So because it is a cause of short limb dwarfism, what will happen to the upper segment is to lower segment ratio in achondroplasia? So short limb dwarfism means the limbs are short. So the lower segment is less, right? So the upper segment, lower segment ratio increases in achondroplasia, right? Easy to remember. Moving ahead, Rett syndrome. So Rett syndrome is an example of X-linked dominant inheritance. Can you give me one more example of X-linked dominant inheritance by the time we discuss Rett syndrome? Waiting for your answers. So Rett syndrome is an X-linked dominant disorder where you get acquired microcephaly. Now, what do you mean by acquired microcephaly? It means that the head circumference is normal at birth, but the baby, as the baby grows, the head size is not increasing as much as it should. So, though head circumference was normal at birth, few months later the baby will acquire microcephaly because of deceleration of head growth. Okay, and there is delayed development and stereotypic hand wringing movements like this. Okay, you can get video like this. Now, yes, very good. So hypophosphatemia, NEET PG is answering, right? So hypophosphatemic rickets is another example of X-linked dominant inheritance. Okay, hypophosphatemic rickets, another very important example of X-linked dominant inheritance. And in hypophosphatemic rickets, the gene involved is the PHEX gene. While in Rett syndrome, many genes can be involved. The most common gene involved is the MECP2 gene. Okay. Moving ahead. Now, a little bit about dentition. Very, very important. We know the milk tooth, the first milk tooth appears at. So many one-liners can come related to normal dentition. You can get true and false type of questions also. So, the first milk tooth or the first tooth appears in the baby at the age of 6 to 7 months. Okay, 6 to 7 months, the first tooth is going to appear in the baby, right? And first permanent tooth is going to erupt at the age of 6 years. The first milk tooth to erupt in the baby we know is the lower central incisor, right? While the first, permanent tooth to erupt in the baby is the first molar. Total number of temporary teeth is 20. Total number of permanent teeth 28 to 32. The last tooth to erupt, last milk tooth to erupt is the second molar. The last permanent tooth to erupt is the third molar or wisdom tooth. And the primary dentition completes at 2.5 to 3 years and secondary dentition completes by 12 years, except of course the third molar, which might erupt at 18 to 25 years or even later than that. So when do you call it delayed dentition? Very important. So even though the first tooth appears at 6 to 7 months, it's not like till 7 months there is no teeth, then you call it delayed dentition. No. So delayed dentition is when no teeth erupts by 13 months of age. So remember, normally the teeth begins to erupt at 6 to 7 months, but if no teeth by 6 plus 7, that is 13 months, then you call it delayed dentition. Okay, delayed dentition. Some important causes of delayed dentition can be familial causes, rickets, idiopathic, endocrine causes like hypopituitarism, okay, then hypothyroidism, hypoparathyroidism, and Down syndrome and cleidocranial dysostosis where the clavicles are absent. Okay, right. So what is the first sign of puberty in females? So n number of times again you've got questions on this. Very, very important one-liner. So the first sign of puberty in females, it is thelarchy or the development of breast. While the first sign of puberty in males is testicular enlargement. And what is the device that we use to measure testicular size? Waiting for your answers. So testicular size is measured by what you are going to tell me. But by the time I am going to tell you that the growth spurt occurs in the females, that means the peak increase in growth velocity occurs in SMR stage 3 in females, while the peak increase in growth velocity occurs in SMR stage 4 in males. Okay, the growth spurt we are talking about, growth spurt, right? Very good. Or Kaidometer. So Shivam, Monica, Jitu, NEET PG. So I'm sure all of you guys are now, very much up to the mark, and this is just a quick revision to brush you up and to get you in that gear, right? So growth spurt occurs later and lasts longer in boys. We all know that, right? Now, in any sick child with medical emergency, ABCD steps are performed. What are these ABCDE? Come on, waiting for your answers. So A is airway. We all know that. A for airway, B for breathing, C for circulation. And very recently in your NEET PG pattern questions, you've got what is the D? So remember, D is not dehydration. D is disability. So you assess the neurological status of the child. You do a quick assessment of the neurological status, whether the child is alert, or the child is responding to voice, or the child is responding to pain, or the child is unresponsive. So alert, voice, pain, unresponsive. So you look for disability. That means you do a quick neurological status assessment of the child. Very good. So I can see you all already answering disability. And E is for exposure. Okay. So you expose the child adequately so that you are able to see all the clinical signs and symptoms, any injury marks if they are there, or any other relevant, physical findings which you might otherwise miss. Right? So moving ahead. So n number of times again, friends, this question has come and you cannot afford to make a mistake on this. So SAM, or severe acute malnutrition in a child, is defined for in a child 6 months to 5 years of age. It is defined as presence of one or more of. So weight for height less than 70% of expected, or less than -3 Z score. So who is going to tell me what is this criteria called? Weight for height less than 70% of expected, or less than -3 Z score of expected. So mid upper arm circumference less than 11.5, or symmetric bipedal edema of nutritional origin. So coming back to the first one, yes. So first one, what is it called? Weight for height less than 70% of expected, or less than -3 Z score of expected, is called severe wasting according to the WHO classification of malnutrition. Right? So SAM, very, very important. And decrease in weight for height is an indicator of acute malnutrition, while decrease in height for age is an indicator of chronic malnutrition. Okay. So very, very important, friends, are the terminologies kwashiorkor and marasmus. You can get case scenarios, you can get images, and you can get questions related to it. So kwashiorkor, we know the three salient differences are, edema. Edema is present in kwashiorkor, but it is absent in marasmus. Sensorium, the child is apathetic, okay? The child is lethargic and listless and not interested in surroundings in kwashiorkor, while the child is otherwise active and alert in marasmus. And the appetite is very poor. The child does not want to eat anything in kwashiorkor. But in marasmus, the child has voracious appetite, would like to eat anything that comes in front of the child. And kwashiorkor is mainly due to protein deficiency in addition to calorie deficiency, of course, and marasmus is mainly due to the energy deficiency. Hepatomegaly, skin and hair changes are more common in kwashiorkor than marasmus. And of course, kwashiorkor, because the child is not willing to eat, the child is listless, apathetic, lethargic, so the prognosis is poorer in kwashiorkor. Very important, right? So, earliest symptom of vitamin A deficiency. So micronutrients, again, friends, are very, very important. You need to remember the signs of micronutrient deficiency. You've read it in your biochemistry also, and otherwise also it's very, very important. So earliest symptom of vitamin A deficiency, again in PSM also you must have read it. So earliest symptom of vitamin A deficiency we know is night blindness. The child will not be able to see during night time properly. While the earliest sign is conjunctival cirrhosis. And we all know there's a WHO grading of vitamin A deficiency, right? Vitamin B deficiency, we know lots of physical findings are there. So glossitis, angular cheilitis, riboflavin deficiency, right? Niacin deficiency, we get a pellagra and we get a Casals necklace rash is there, okay? Pyridoxine deficiency can cause neonatal seizures also. So we need to remember the signs of various, micronutrient deficiencies, beriberi, thiamine deficiency, and so on, right? Now, zinc deficiency needs special mention, has been asked previously, acrodermatitis enteropathica. It is a condition where zinc does not get absorbed properly, okay? So what happens? There are rashes around the orifices, around the oral cavity, around the anal cavity, and on the extremities. So acrodermatitis enteropathica is there. These children have diarrhea, okay? So recurrent diarrheas are there. And zinc deficiency can lead to growth failure, diarrhea, hypogonadism, alopecia, and poor wound healing. So you have to supplement zinc in these children and they improve with that, right? So moving ahead, calculation of maintenance fluid in children, very, very important. You can get a case scenario where a child is admitted for some reason and you have to start IV fluid. So what is the amount that you're going to give? So remember, for the first 10 kgs, it is 100 ml per kg. So by the time we are discussing this, who can tell me the fluid requirement in 24 hours for a 14 kg child? Okay. So the first 10 kgs, it is 100 ml per kg. Next 10 kgs, it is 50 ml per kg, and beyond 20 kgs, you give 20 ml per kg. The fluid used in older children, usually we use dextrose normal saline with 1 ml KCl per 100 ml. Okay, 1 ml KCl per 100 ml. Right, so this is the fluid which is used in children as such. Okay, about the neonates, we'll just be coming to it. So 14 kg, very good. So Kavya, Shubham, Nishchay, Shrestha, very good. So it is 1200. So 14 kg child, the first 10 kgs, it will be 10 into 100, that means 1000 ml. Okay, and for the next 4 kgs, it is going to be 4 into 50, that is 200. So it is going to be 1200. So 1200 ml in 24 hours, right? So that is how you will give this fluid. Okay. Now, how do you calculate the intravenous fluid requirement in neonates? So in neonates, if the neonate's birth weight is less than 1500 grams, that means less than 1500 gram neonate, what is it called? So who is going to tell me what is a neonate with a birth weight less than 1500 gram called? I'm waiting for your answer. So less than 1500 gram, you start with 80 ml per kg per day. And if the baby's birth weight is more than 1500 grams, you start with 60 ml per kg per day. And you go on increasing with 15 to 20 ml per kg per day. Okay. And by the end of 1 week, you reach a fluid of 150 ml per kg per day. Okay, this is ml per kg per day. So what did we ask? Yes, very low birth weight. It's not extremely low. Less than 1500 grams is very low birth weight, and less than 1000 gram birth weight is called extremely low birth weight. Okay. What is the SDA baby? SDA or small for gestational age? It is a baby whose birth weight is less than 10th percentile of expected according to the gestational age. Okay. So in neonates, we saw the starting fluid. We saw by 1 week we give 150 ml per kg per day, and the fluid which is given in the first 48 hours is 10% dextrose. So if the baby is requiring IV fluid, you give 10% dextrose with no electrolytes. If the baby is is able to breastfeed and there are no contraindications to breastfeeding, then of course intravenous fluids are not required normally. Okay. So maintain glucose infusion at the rate of 4 to 6 mg per kg per minute, and sodium and potassium are added to the IV fluid only after 48 hours. Right. So breast milk, very, very important, guys. The composition of breast milk, the advantages of breast milk, signs of good positioning, signs of good attachment, contraindication of breastfeeding, very, very important. We've discussed all these. So breast milk contains, more lactose and lesser protein than cow's milk. Okay. And we all know the qualities of protein that breast milk has: more cysteine, taurine, methionine, and so on. And breast milk is richer in whey proteins as compared to casein and cow's milk, right? And breast milk contains adequate amounts of all the vitamins except, very, very important, vitamin D, vitamin K, and vitamin B12 in strictly vegan mothers, right? So moving ahead, for how long can express breast milk be stored? It depends on the temperature at which you're storing it. So at room temperature, you can store it for 8 to 10 hours, in a refrigerator for 24 to 48 hours, and in a deep freezer for almost 3 months. So that there comes the concept of, breast milk banks are available nowadays, right? So moving to a little bit about genetics and dominant disorders. So in dominant disorders, at least one of the parents is usually affected. So in a pedigree you're getting, if either of the parents is affected, then it is a dominant disorder. Okay. Now father to son transmission. If there is a father to son transmission, then it will rule out X-linked inheritance. So in a pedigree, if you're getting that father is also affected, son is also affected, it is not X-linked inheritance. Okay. It has to be autosomal, right? So Fragile X syndrome, very important, friends. I have made a separate video on this also, but Fragile X syndrome we know is due to trinucleotide repeat expansion. So it is due to more than 200 CGG repeats, very important, okay? And loss of function mutation of the FMR1 gene is seen. The clinical features of Fragile X syndrome: elongated face, large ears are there, okay? Large prominent square jaw is there. And in post-pubertal males, you also get macroorchidism. These males have intellectual disability. The mean IQ of these males is around 40. Okay. Females are less commonly affected, and even out of the affected females, only 25% are going to have intellectual disability. But behavioral disorders can be there, right? Now, biochemical markers used for antenatal screening of Down syndrome. So antenatal screening of Down syndrome, very, very important. So in the first trimester, remember the biochemical markers which are used are PAP-A and beta-HCG only, right? While in the second trimester, okay, in the second trimester, you can do your triple test and quadruple test. So triple test and quadruple test are done in the second trimester. So triple test, the components, very, very important. You can get a question, all of the following components of triple test except. So waiting for your answers. So triple test, what are the components? So they are beta HCG, alpha fetoprotein, and unconjugated estriol, right? And quadruple test is all the components of triple test plus inhibin. Okay. So very good. Yes. So I can see you guys answering. So inhibin, right? So which of these markers are going to increase? So remember HI high. Okay. So in Down syndrome, the level of HCG is going to increase and the level of inhibin is going to increase. Rest all parameters are going to decrease. Okay. Apart from that, in first trimester, you can get increased nuchal thickness, which is suggestive of Down syndrome. And the confirmatory test for antenatal diagnosis of Down syndrome is fetal karyotype. So you have to do a chorionic villus sampling or amniocentesis, and you do a fetal karyotype to confirm the diagnosis. There is one more screening test also which is available, that is called NIPS, non-invasive prenatal screening, where you use maternal blood and you detect the cell-free fetal DNA in the maternal blood. Okay, so that is again very important, right? Now, in an antenatal scan, if you're getting multiple fractures in the baby, what will you think of? So a disorder where so many fractures happen in the baby. So the bones are very, very fragile, okay, and they fracture easily. You think of osteogenesis imperfecta. So it is a collagen disorder. Autosomal dominant is the most common type of inheritance, and there's a triad of clinical features that you can get here. We all know. So they are blue sclera, recurrent fractures or bony deformities, and sensory neural hearing loss or deafness, right? So moving ahead, the most common chromosomal abnormality. So incidentally, it is the 21st fact, and we know Down syndrome. What is the chromosomal abnormality? So waiting for your answers. So most common chromosomal abnormality is Down syndrome among children, of course. Okay. But if you ask me which is the most common trisomy, so it is trisomy 16. But most of the fetuses with trisomy 16 are going to get aborted. So among the children, if you ask me again, the most common chromosomal abnormality is Down syndrome. Yes. So Down syndrome, we all know, is 3 copies of chromosome 21 are there. So it is trisomy 21. Very good. Right. So which is the most common mechanism by which it happens? It is maternal meiotic non-disjunction. Okay. So very few cases are due to Robertsonian translocation, and 1 to 2% cases you can get mosaicism also. Okay. Now, most common glycogen storage disorder. Most common glycogen storage disorder in children we know is von Guericke disease or type 1 GSD. What will be the typical presentation? The child will have a doll-like faces and recurrent episodes of hypoglycemia leading to early morning lethargy or early morning seizures can be there. There can be abdominal distension because there is huge hepatomegaly in these babies. On investigation, you can get hypoglycemia, you can get lactic acidosis. Okay, elevated lactic acid levels, elevated uric acid levels you can find. Okay, so that is the presentation of von Guericke disease. Okay. Now, the most common enzyme deficient in galactosemia. So, galactosemia again is a very important disorder of carbohydrate metabolism. What are the other enzyme deficiencies that can cause galactosemia? Who is going to tell me? Let us see. So, most common enzyme deficiency which is causing galactosemia we know is GART, that is galactose 1-phosphate uridyl transferase. But there are 2 other enzymes also whose deficiency can cause galactosemia, though less commonly. What are they? So, they are, yes. So, yes, very good. Ankit answered, I saw. So, galactokinase is one enzyme and another one is epimerase. Okay. So, the features of galactosemia we all know are they can be congenital cataracts or oil drop cataracts also some people say. So, congenital cataracts can be there. There can be hypoglycemia and there can be jaundice, diarrhea, vomiting and so on. And you have to avoid lactose, okay, because lactose contains glucose and galactose. So it is one of the absolute contraindications to breastfeeding. Okay, so if a child has confirmed case of galactosemia, then breastfeeding is contraindicated. Okay, breastfeeding is contraindicated in a confirmed case of galactosemia. Similarly, in a confirmed case of lactose intolerance, primary lactose intolerance, also breastfeeding would be contraindicated. Okay, and contraindications related to the mother, it will be like mother on radiotherapy or chemotherapy are absolute contraindications, and the other infective conditions in the mother are relative contraindications. So based on the situation, you have to weigh the risks and versus benefits. You have to take the call, right? Moving ahead, in phenylketonuria. So phenylketonuria, we know what is the enzyme deficient? Phenylalanine hydroxylase. The baby will be hypopigmented because melanin is also not getting synthesized. There will be spasticity, seizures, a lot of CNS manifestations. Okay, and ferric chloride test with urine gives green color in phenylketonuria. Remember, while in maple syrup urine disease, so maple syrup urine disease, there's a problem with the branch chain amino acid metabolism. So accumulation of isoleucine, leucine, valine, right? And here the ferric chloride test with the urine gives a blue color. And another important question which has been asked previously is alkaptonuria. Alkaptonuria, the only manifestation in a child is the mother will come and say that, the diaper of the baby becomes dark after some time. So darkening of urine on standing is seen in alkaptonuria. What is the enzyme deficient in alkaptonuria? Yes, waiting for your answers. So alkaptonuria, you're going to tell me the enzyme deficient. In older individuals, alkaptonuria can present with arthritis and, deposition of alkapton bodies and dark spots on sclera or on the ear cartilage. So the enzyme deficient, very good Keshav. So homogentisate oxidase. Yes. Now, a child with seizures and lethargy. Okay, if a child is having seizures and lethargy, so seizures, lethargy with metabolic acidosis with some skin rashes or alopecia. Okay, so if you're getting a presentation of CNS involvement is there, non-specific features with metabolic acidosis and with skin rashes and alopecia, think of something to do with biotin. So it can be seen in biotinidase deficiency or it can be seen in multiple carboxylase deficiency, because in multiple carboxylase is an enzyme where biotin is a cofactor. So these are treatable conditions. Lifelong supplementation of biotin may be required, but they improve very well with biotin. Okay. Moving ahead, metabolic diseases in which cherry red spot is seen. So cherry red spot, if you're getting on examination of fundus, you think of metabolic disorders like GM1 gangliosidosis. So it is a disorder where, there is a beta galactosidase enzyme is deficient. So the baby has coarse facial features, hepatosplenomegaly, bony changes and so on. Okay. So GM1 gangliosidosis, Niemann-Pick disease and Tay-Sachs disease. These are the important metabolic diseases or storage diseases where you get cherry red spot. Gaucher disease, commonly you do not get a cherry red spot. Okay, don't confuse. Now, enzyme replacement therapy. It is available for many metabolic disorders, but the important ones that we must remember are It is available for Gaucher disease, very, very important. Gaucher disease, Hurler disease, Pompe disease, Fabry disease, it is available, and Niemann-Pick disease, it has recently become available. Okay. So, moving ahead, if you're getting a case scenario where you're getting a palpable purpura, okay. So, if you're getting a palpable purpura, so uh, Ankit, so Gaucher disease, usually cherry red spot is not found. Rarely you may get it. Usually it's not found. Okay. So palpable purpura in a child with presence of one or more of arthritis, arthralgia, or abdominal pain, or renal involvement, or any biopsy showing IgA deposition, then think of Henoch-Schönlein purpura. Okay. So very important, Henoch-Schönlein purpura is a self-limiting disorder. Mostly only supportive care is required. No other treatment is required. But if you are asked about one treatment which has been asked in the NEET PG exam recently, so then if you have to choose a treatment option, it is going to be corticosteroids. So if required in severe disease, we give steroids. Whereas Kawasaki disease, we know the diagnostic criteria: fever for more than 5 days with any 4 out of the 5 cream features, and the treatment of choice is IVIG, intravenous immunoglobulin. Okay. Congenital CMV. Remember, this congenital cytomegalovirus infection is the most common non-genetic cause of sensory neural deafness in children. So congenital CMV, 80% of the babies remain asymptomatic. Only 20% are going to have features. And those babies in which, mothers had primary infection during pregnancy have more chances of getting, congenital CMV than, mothers with secondary infection. Okay. And there can be various manifestations, like there can be hepatitis in the baby, there can be retinal changes, there can be chorioretinitis, microcephaly can be there, low birth weight baby can be there, right? So IUGR, so a lot of things are possible. Now, congenital rubella syndrome, another very important disorder. It presents classically with CDC. CDC, what is CDC? C for cataract, D for deafness, C for congenital heart disease. Among the congenital heart diseases, most commonly it is PDA or patent ductus arteriosus. Apart from that, also other manifestations are also possible: chorioretinitis, IUGR, and blueberry muffin spots. So where you have some erythropoiesis going on elsewhere. So all those are also possible, right? Moving ahead, hypoplasia of limbs. Okay, if you are getting limb hypoplasia and scarring, okay, scarring of the skin, it is caused by congenital varicella. So if the mother has a history of having varicella during pregnancy, then the baby can be born with congenital varicella syndrome, right? Hutchinson's triad, very, very important. N number of times has come in various MCQs. So Hutchinson's triad, of course, it is a triad. So 3 things. What are the 3 things? One is interstitial keratitis, involvement of eye. Another is sensory neural deafness, involvement of ear. And another is Hutchinson's teeth. So what are Hutchinson's teeth? So they are peg-shaped, or these peg-shaped or notched incisors are Hutchinson's teeth. So Hutchinson's triad is a late feature of congenital syphilis. So congenital syphilis clinical features important, right? Now, pleomorphic skin rashes. What do you mean by pleomorphic skin rashes? That means various types of rashes at the same time. Same time, you're getting macule also, papule also, pustule also, vesicle also, crusted lesions also. Think of varicella. Okay, varicella or chickenpox. While if you're getting erythematous maculopapular rash, which becomes confluent at places with conjunctivitis and coryza, think of measles. Okay. Now, the most common complication of measles is otitis media. But the most common cause of death due to measles is pneumonia. And measles is happening a lot nowadays. So, it is very, very important to immunize all children against it, right? Now, national immunization schedule, friends, very, very important. And I'm sure all of you are very, very thorough with it. So, the vaccines given at birth, we all know are BCG, OPV, and hepatitis B, OPV 0 dose. Okay. I'm not going into details, but very, very important is the recent update, that is both fractional IPV and pneumococcal conjugate vaccine are now recommended at 6 weeks, 14 weeks, and 9 months also in the national immunization schedule. Very important for you to remember, right? Now, if a measles epidemic is going on, and if the first dose of measles vaccine was given at 7 months, has been asked recently, then what do? So you still give the first dose at 9 months and next at 16 to 24 months. Don't count this dose of 7 months that you've already given. Okay. And don't, just give the booster at 16 to 24. Give the dose at 9 months also. Give the dose at 16 to 24 months also. Okay. Now, open vial policy, friends, very, very important. So what do you mean by open vial policy? So open vial policy means, what happens if, a vaccine vial has 10 doses. You've used only 2. So what will you do with rest if no other children are there that day? So if that vaccine is following open vial policy, then you can reuse it in the next immunization session. So that is the whole purpose of open vial policy. Now, so this open vial policy allows the reuse of partially used multi-dose vials of certain vaccines. Which vaccines follow open vial policy? So OPV, IPV, pentavalent, and they can be used up to 28 days, provided expiry date of vaccine has not passed. So you all will be telling me which vaccines do not follow open vial policy. Waiting for your answers. Okay. So provided expiry date of vaccines has not passed, cold chain is properly maintained, aseptic precautions have been taken, and a vaccine vial septum is not leaking. So vaccines which do not follow the open vial policy, what are those vaccines? Yes, waiting for your reply. So BCG does not follow. The measles and measles containing vaccines do not follow. Rotavirus vaccine does not follow the open vial policy. Okay. Right. Moving ahead, serious adverse effects of DPT vaccine. Very important. Serious adverse effects of DPT vaccine. What are they? Persistent crying for more than 3 hours. Very high grade fever of more than 40.5 degrees Celsius. Seizures, okay, after DPT vaccination. Hypotonic, hyporesponsive episodes and encephalopathy. So they are very, very important side effects of DPT vaccine. Okay. And DPT is contraindicated if there is a history of anaphylaxis or encephalopathy within 7 days of previous dose, or if a child is having progressive neurological disorder, then you avoid DPT. Okay. Moving ahead. Now, important causes, if you're getting a case scenario where the baby has not passed meconium within 24 hours. So we all know that the baby should pass meconium within 24 hours and first urine within 48 hours. So if the baby has not passed meconium in the first 24 hours, what will you think of? You can think of Hirschsprung disease, where these neural crest cells have not migrated to the intestine, and there is absence of ganglion cells in the intestinal wall, or cystic fibrosis, where the secretions are totally dehydrated. You can get meconium ileus and even meconium peritonitis, right? Moving ahead. Now, neonatal hypothermia, the definition is very, very important. Axillary temperature. So, neonatal hypothermia is defined as axillary temperature. How much? Yes, who will tell me? Axillary temperature less than how much? 36.5 degrees Celsius in a neonate. Okay. And there are 3 categories of neonatal hypothermia. Cold stress is 36 to 36.4. Moderate hypothermia 32 to 35.9, and severe hypothermia is axillary temperature less than 32 degrees Celsius in a neonate. And if you're touching a baby, both the abdomen and the soul should be warm to touch. If the abdomen is warm but the soles are cold, the baby is said to be in cold stress. And if both are cold, then the baby probably has hypothermia. Okay. Now, if a neonate, okay, is found to have a heart rate of less than 100 per minute at birth, what will you do? Start positive pressure ventilation. And who will tell me what is the oxygen recommended at this time? How much oxygen will you give when you start positive pressure ventilation? Waiting for your replies. Meanwhile, if the heart rate now becomes, further less, if the heart rate becomes less than 60 per minute, then what do? You give chest compressions along with positive pressure ventilation, okay? And use 100% oxygen now. Still, if the baby does not improve, you use injection epinephrine. So you can get case scenarios where you have to, decide what do you do as the next step. Yes. So very good, guys. So when you start positive pressure ventilation, I can see the dancing Dr. Neelam, Lakesh, Uzma, Mohit, all of you are right. Very good. Awesome. So when you start positive pressure ventilation, okay, initially you start with room air or 21% oxygen. Okay. So room air, that means 21%. Okay. Now, in neonatal resuscitation, if you're doing both, chest compression is to positive pressure ventilation, it is to be given at the ratio of 3:1, remember, nothing else. Okay. Moving ahead. One very important absolute contraindication of bag and mask ventilation is congenital diaphragmatic hernia, where there is a diaphragmatic defect and the bowel loops have herniated into the thorax. Okay. In congenital diaphragmatic hernia, if the baby is having respiratory distress or bradycardia, you do endotracheal intubation and do bag and tube ventilation and not bag and mask ventilation. Right? Okay. Now, what are the causes of asymmetric Moro's reflex? Remember, friends, Moro's reflex is very, very important. What happens in Moro's? Moro's reflex normally is symmetric. So there is symmetric abduction, okay, abduction and extension of upper limbs along with opening of hands, followed by adduction and flexion, okay, and movement of lower limbs and crying and neck extension. So when Moro's becomes asymmetric, it is important and abnormal. So what happens? When there is fracture clavicle or shoulder joint dislocation or congenital hemiplegia or Erb's palsy, you can get an asymmetric Moro's reflex. Remember, clavicle is the most common bone to fracture in a neonate also. Okay? Right. The most common type of seizures in neonate, it is subtle seizures. The most common cause of seizures in neonate is hypoxia. Okay? The type of neonatal seizures with best prognosis is focal clonic, worst prognosis myoclonic seizures. What is the drug of choice for neonatal seizures? Who will tell me the drug of choice for neonatal seizures? Waiting for your answers. So very good, Ravi. So drug of choice for neonatal seizures is phenobarbital. Okay, phenobarbital. Right? And the imaging, the intracranial imaging of choice for neonates is the transcranial ultrasound through the open anterior fontanelle. Okay. Now, remember in HIE or hypoxic ischemic encephalopathy, the baby is hyper alert in stage 1. Okay, very, very alert, and the Moro's reflex is exaggerated. While in a baby with perinatal asphyxia, if you are getting seizures, it is always stage 2 HIE. Okay, seizures, remember, are a feature of stage 2 HIE. But if the baby is, totally hypotonic, lethargic, flaccid, limp, and Moro's reflex is absent, then it is stage 3 HIE. So it has been asked previously. So if a case scenario has been given, you should be able to make out whether it is stage 1, 2, or 3 HIE simply, right? Now, what is the preferred initial mode of feeding in a neonate, in a preterm neonate? So if the baby is born at less than 28 weeks gestation, the baby's gut is too immature, it cannot handle anything. So you give IV fluids only, with or without TPN, or total parenteral nutrition has to be given. Nothing in the intestine. Okay. Now 28 to 31 weeks, if the baby is born, you start with orogastric tube feeding, or it is also called gavage feeding. Okay. 32 to 34 weeks, if the baby is born, you can start katori spoon feeding, and beyond 34 weeks, direct breastfeeding can be started. So depending on the gestational age of the baby, you decide the preferred initial mode of feeding, right? Now this cephal hematoma, two very important swellings involving the head from which you often got questions. So this cephal hematoma, remember friends, it is a bleeding subperiosteal hemorrhage involving the cranial bones. It takes 24 to 48 hours to appear and 5 to 7 weeks to disappear. And it does not cross sutures or midline usually. While capered succedaneum is another boggy swelling due to edema in the layers of the scalp. So capered succedaneum, if it is to be present, it is present already at birth in its maximum size and it disappears in 48 to 72 hours. Who can tell me which of these predispose to neonatal jaundice, cephal hematoma or capered? Waiting for your answers. Meanwhile, we move ahead. Kangaroo mother care, very important friends. Advantages of kangaroo mother care, again n number of times it has been asked previously. So kangaroo mother care, baby is kept in skin contact with the mother. So there are lesser chances of neonatal hypothermia, lesser chances of nosocomial sepsis, lesser duration of hospital stay, and higher exclusive breastfeeding rates. Yes, so very good. Cephal hematoma predisposes to neonatal jaundice because it's a collection of blood. Blood has hemoglobin, so hemoglobin breaks down to heme, biliverdin, bilirubin, right? Now, most common congenital abnormality in infant of diabetic mother is congenital heart diseases. Among the congenital heart diseases, the most common would be BSD, but the most specific would be TGA. Now, who can tell me what is the most specific congenital abnormality in infant of diabetic mother? Most specific abnormality in infant of diabetic mother. What is it? So it is, waiting for your replies, most specific abnormality in infant of diabetic mother. So it is very good, Rameshwar Vrushali. So it is sacral agenesis, or it is also known as caudal regression syndrome. Okay. While the most common neurological abnormality would be neural tube defects. And of course, these babies are going to have macrosomia, so large for dead baby. They'll have hypoglycemia, hypocalcemia, hypomagnesemia, but they can have jaundice and polycythemia as well. Okay. And respiratory distress syndrome due to delayed maturation of surfactant. Right. Very good. So I can see all of you answering. So most important mechanism by which phototherapy acts is structural isomerization. So if a baby is kept under the blue light, it is phototherapy, okay? And 450 to 460 nanometer is the most effective wavelength. Closer the baby to the phototherapy unit, better it acts, and more the exposed surface area, more it will act better. So what are the important adverse effects of phototherapy? Very, very important. So let us see some of the adverse effects if you can write down. So adverse effects of phototherapy we know are like bronze baby syndrome, where the color of the skin of the baby becomes darker. Okay. So bronze baby syndrome, what else? So bronze baby syndrome, hypocalcemia, watery diarrhea. Okay, diarrhea can be there, dehydration can be there. Okay, dehydration, there can be retinal toxicity, there can be gonadal toxicity. Okay, retinal toxicity and gonadal toxicity. That is why you cover the eyes and genitalia of the baby. Okay. Moving ahead, most important risk factor for NEC or necrotizing enterocolitis is prematurity. Though 10% case of NEC can happen in term babies also, right? So the most common type of congenital diaphragmatic hernia, we know it is the posterolateral or Bogdalek variety, right? Moving ahead, the most common cause of neonatal sepsis in India. So as per the latest studies, it is Acinetobacter is most common, followed by Klebsiella. Okay. Now, the most common congenital heart disease affected by infective endocarditis, it is ventricular septal defect. Ventricular septal defect, friends, is also the most common congenital heart disease seen in children. It is also the most common acyanotic congenital heart disease in children. The murmur, we all know classically ventricular septal defect, what kind of a murmur will be there? Pansystolic murmur. Atrial septal defect, what will be the auscultation finding? No murmur as such usually, but there will be a wide fixed split of the second heart sound. Okay, wide fixed split of the second heart sound. PDA, what is the murmur? You're going to tell me. What is the murmur? Classically, we get in patent ductus arteriosus. And what is the murmur we get in tetralogy of Fallot? So, tetralogy of Fallot, we get a ejection systolic murmur in the pulmonary area. Waiting for your answers. PDA, what kind of murmur do you get? Patent ductus arteriosus. So, very good, Ankit. Nishchay. Okay, so we get a continuous word is very important. Okay, continuous machinery murmur. Okay, continuous machinery murmur in patent ductus arteriosus. Right. The most common congenital heart disease in Down syndrome, remember, is atrioventricular septal defect or endocardial cushion defect. Okay. The most common congenital heart disease which you get in Turner syndrome is bicuspid aortic valve. Okay, bicuspid aortic valve followed by coarctation of aorta. Right. The most common congenital heart disease that you get in Noonan syndrome is pulmonary stenosis. Okay. And in Williams syndrome, the most common congenital heart disease that you get is supravalvular aortic stenosis. Supravalvular aortic stenosis. Right? Moving ahead, the most common congenital heart disease that causes mortality in the first week of life is hypoplastic left heart syndrome, HLHS. Okay? Or it is also called hypoplastic left ventricular syndrome. Okay? Yes. The conditions which worsen with prolonged infusion of prostaglandin E. So, in certain ductus dependent conditions, we can use prostaglandin E, PGE1, to keep the ductus open. But if you give it an obstructed TAPVC, the baby's condition worsens instead of improving. Okay, so it is contraindicated, right? Now, what is a drug which can be used to close ductus? To close the ductus arteriosus, which is the drug? Waiting for your answers. So, to close the ductus arteriosus in preterm babies, what is the drug that we can use? So, we can use indomethacin or ibuprofen. Okay, ibuprofen has a better side effect profile than indomethacin, so it is preferred. Both are almost equally efficacious. In fact, there are some newer studies which shows that even paracetamol also helps in closure of this ductus arteriosus by being a prostaglandin inhibitor. Now, in fetus, so we all know the fetal circulation, not going to detail at this moment, but in fetus, maximum oxygen saturation is found in umbilical vein, followed by inferior vena cava. While minimum oxygen saturation we know is found in the umbilical artery, which carries the blood back to the placenta for oxygenation. Now, in a child with acyanotic congenital heart disease like ventricular septal defect or patent ductus arteriosus or atrial septal defect, if you are getting cyanosis and clubbing, think of Eisenmenger syndrome. You can get case scenarios where a child with VSD develops cyanosis and clubbing. Think of Eisenmenger syndrome. But if a child with VSD is developing, clubbing along with fever, think of infective endocarditis. Okay. Now, the most common cause of cyanosis, in a child is tetralogy of Fallot. That means the most common congenital heart disease in children is tetralogy of Fallot. But during infancy, if you ask me most common congenital heart disease, it is mostly TGA or transmission of great arteries. Okay, right. Now, atrial septal defect. Remember, it is not a component of tetralogy of Fallot. We all know what are the four components of tetralogy of Fallot. So they are, so large VSD, pulmonary stenosis, overriding of aorta, and right ventricular hypertrophy. So ASD is not a component. But remember, ASD is a component of trilogy of Fallot and pentalogy of Fallot. But it's not a component of tetralogy of Fallot. Now, X-ray findings in the congenital heart disease is very, very important, have been asked a number of times. Egg on side appearance, we all know is seen in TGA or transmission of great arteries. Boot-shaped heart or core and sabot appearance in tetralogy of Fallot. Snowman appearance, where do you get it? So, snowman appearance, friends, we get it in TAPVC supracardiac type. It is also called figure of eight appearance. And box-shaped heart or huge cardiomegaly in Epstein anomaly. Who can tell me the ECG finding classically what is seen in Epstein anomaly? Waiting for answers. Moving ahead. The most common primary intraocular tumor in children is retinoblastoma. And the most common presentation of retinoblastoma in children is leukocoria or white reflex from the pupil. Yes. So Himalayan P waves. Very good, Shubho Bhattacharya. So Himalayan P waves are what you get in Epstein anomaly on ECG. The drugs used for iron chelation in a child with thalassemia. So when do you start iron chelation in a child with thalassemia? We start it when the serum ferritin becomes more than 1000 nanogram per ml. And the drugs which can be used are desferrioxamine, deferriprone or deferrasilox. Out of that, the deferriprone and deferrasilox can be given orally, while desferrioxamine has to be given either as a subcutaneous or an intravenous infusion. Okay. Now, the most common viral agent causing diarrhea in children, we all know it is rotavirus. Okay. The treatment of diarrhea in children, very, very important. Give WHO ORS, give zinc. Okay. Give ORS, give zinc and continue normal diet. Okay. The most common extraintestinal manifestation of celiac disease we know is refractory iron deficiency anemia. And otherwise, the celiac disease causes, recurrent episodes of diarrhea, bloating, failure to thrive, and vomiting and all can be there, abdominal distension can be there, and so on. The most common cause of portal hypertension in children in India is extrahepatic portal venous obstruction. So if you're getting a child with bleeding varices, splenomegaly, okay, but the liver functions are normal, think of extrahepatic portal venous obstruction. The most common cause of stridor in a neonate or in a young infant is laryngomalacia. And this stridor increases on crying and during feeding and improves in the prone position, usually requires no treatment. The most common cause of common cold in children we know is rhinovirus, right? Now, what is the most common cause of croup? So, croup is a very important condition which we discussed previously also in detail. You can get case scenarios. You can be asked about treatment of croup also. So, do revise it. So, most common cause of croup is parainfluenza virus. So, it is a viral illness. On X-ray, we get the steeple sign. For treatment, we use, single dose dexamethasone. That means steroids are the treatment of choice, and nebulized epinephrine can be required in moderate to severe cases. While, acute epiglottitis is a more severe illness. It is a bacterial illness. The most common cause in immunized population is streptococcus. Okay. Previously, it was H influenza. The treatment we already discussed of the mild group, dexamethasone and epinephrine, and in severe cases you give epinephrine and oxygen and IV fluids. The most common cause of bronchiolitis is respiratory syncytial virus. So bronchiolitis we typically suspect in the 6-month to 3-year age group when a baby presents with cough and prodromal features of viral like low grade fever is there, respiratory distress, cough is there, and hyperinflated chest can be there. When you auscultate, some wheeze is there, chest X-ray may show hyperinflation. So that is a typical presentation of bronchiolitis, and the causative agent is respiratory syncytial virus most commonly. The most common cause of idiopathic nephrotic syndrome in children, which responds to steroid, is minimal change disease. It's called minimal change disease because light microscopy is going to show no clinical features, right? But the electron microscopy shows flattening of foot plate of podocytes. So Arjun asked me, what is the treatment of acute epiglottitis? Treatment of acute epiglottitis, friends, because it is a bacterial illness, we use injection ceftriaxone. Third generation cephalosporin is used as treatment, apart from, of course, oxygen, IV fluids, and supportive care. Okay. Now, Schwartz formula for calculation of estimated GFR in children, very, very important. So if you're getting a child having decreased urine output, deranged urea creatinine, and you are asked what is the estimated GFR of this child, use the formula, Schwartz formula, where K, the estimated GFR is given by K into length in centimeters by serum creatinine. Okay. So K, the constant is 0.41. So use it as 0.4. Okay. So 0.4. So if the length of a child is 100 centimeters, and the serum creatinine is 1 milligram per dl, then how much will be the estimated GFR? Waiting for your answers. So estimated GFR in a child whose height is 100 centimeters and creatinine is 1. So it will be 0.4 into 100 by 1. So it will be approximately 40. Right? Okay. Very good, Sachin. So hemolytic uremic syndrome, HUS, we know, is a triad of microangiopathic hemolytic anemia. Now, who can tell me what is the evidence of microangiopathic hemolytic anemia in peripheral smear in HUS? Waiting. So hemolytic anemic uremic syndrome is a triad, microangiopathic hemolytic anemia, thrombocytopenia, and renal insufficiency is there. Okay. And for the treatment, you use plasmapheresis. Plasma exchanges are used. Okay. And you may require thrombocytopenia is there. You may require to give platelets also if bleeding manifestations are there. Okay. And eculizumab is a newer drug which is used in treatment of atypical HUS. Eculizumab. Yes, schistocytes. Very good. Shrita Sharma. So schistocytes are the evidence that you get in peripheral smear in HUS. Right? So moving ahead, staging of acute kidney injury, very important. When you call it acute kidney injury, when the serum creatinine increases by more than 0.3 milligram per dl from the baseline, or it becomes 1.5 to 1.9 times the baseline, or the urine output of the child decreases to less than 0.5 ml per kg per hour for more than 6 hours, then you call it acute kidney injury in children. And that is stage 1. Okay. So stage 2 is when the creatinine becomes 2 to 3 times the baseline, and the urine output, the decreased urine output is there for more than 12 hours, then it is stage 2. And if it is more severe than that, then it is stage 3 of acute kidney injury. Okay. Right. Moving ahead, what is the most common cause of hydronephrosis in a newborn? It is PUJ obstruction. Okay. Pelvic junction obstruction is the most common cause. Okay. You can get hydronephrosis, and it can be detected even antenatally. The most common cause of urinary obstruction, lower urinary obstruction in boys, is the posterior urethral valve, okay, or PUV. Very, very important. The most common cause of pyelonephritis and recurrent urinary tract infection in children is VUR, vesico-ureteric reflux, where what happens? Now urine goes from the bladder to the ureters, and it can even reach the renal, pelvis and the kidneys. Okay, so very important and severe condition. The most common cause of gross hematuria in children 1 to 2 days after a acute respiratory infection, you think of IgA nephropathy. Who can tell me if you're getting a hematuria in a child 1 to 3 weeks after upper respiratory tract infection, what do you think of? So hematuria, if it is occurring 1 to 3 weeks after upper respiratory tract infection, what do you think of? So you think of, yes, very good. Vrushali, Vedehi, Shruti, Pooja, Kavya, Shiana, very good. Then you think of post-streptococcal glomerulonephritis or post-infectious glomerulonephritis. Okay, very good. So moving ahead, the most common cause of congenital hypothyroidism in a child is thyroid dysgenesis. While the most important cause of congenital hypothyroidism in a child with goiter is thyroid dyshormonogenesis. Okay, very important to detect it by newborn screening. TSH is usually used. TSH more than 20 is indicative of possibility of congenital hypothyroidism, and you need to repeat it and confirm it and start treatment as soon as possible. Okay, the most common cause of CAH or congenital adrenal hyperplasia is 21 hydroxylase deficiency. It has got autosomal recessive inheritance. Antenatal diagnosis is possible. The drugs used in the treatment are hydrocortisone and fludrocortisone. Okay, right? And during pregnancy, who can tell me antenatally what is the drug that you will give to the mother if you're suspecting a case of CAH, or in a high risk female who already has a previous baby with CAH, what is the drug used? Waiting for your answers. So most common cause of Cushing syndrome is prolonged exogenous administration of glucocorticoids. So iatrogenic cause is most common cause of Cushing syndrome in children. Yes, very good. So Oishi, dexamethasone is given to the mother if we are suspecting that the mother has a baby with CAH based on the previous pregnancy history. The most common cause of seizures in a child less than 5 years of age is febrile seizures. Okay, febrile seizures are very, very important. And febrile seizures we know are simple febrile seizures, complex febrile seizures. Simple febrile seizures are generalized, lasting for less than 15 minutes. Okay, and they are only single episodes in a child with fever. In one episode of fever, only one time seizure is going to happen in simple febrile seizure. Usually no antiepileptics are required long term. The most common location of meningomyelocele, which is a neural tube defect, we know is the lumbosacral region. Okay, and what is the dose of folic acid? Again, n number of times has come in various questions. The dose of folic acid used for the prevention of neural tube defects. So it is 400 microgram per day for all children, all ladies of the childbearing age group. Okay, all women of childbearing age, and it is 4000 microgram per day or 4 milligram per day in high risk women, and it is to be started before at least 1 month before conception. Okay. Now, what is the treatment of choice for infantile spasms or West syndrome? The treatment of choice is ACTH, injection adrenocorticotropic hormone. While the treatment of choice in a child with West syndrome or in a child with infantile spasms in tuberous sclerosis, it is vigabatrin. We've already discussed that. Yeah. So, most common cause of an elevated CSF opening pressure. So, if if your baby is there and you're getting a bulging anterior fontanelle, the most common cause would be the baby is crying. So, when the baby is crying, don't examine the anterior fontanelle. Preferably examine when the baby is calm and composed. And when you're doing CSF also, if it is an agitated patient, you can get a elevated CSF opening pressure. So, it is one of the most important or common causes of raised intracranial tension, falsely read you get it. Okay. Most common neurobehavioral disorder of childhood is ADHD or attention deficit hyperactivity disorder, right? In a floppy child, so floppy child means the child is totally hypotonic, having a frog-like posture. So in a floppy child with normal social and cognitive milestones with tongue fasciculations, we think of SMA or spinal muscular atrophy. Okay, spinal muscular atrophy. So who can tell me name of a drug which has recently come for spinal muscular atrophy for the treatment? SMA. So spinal muscular atrophy. I'll be waiting for your reply. Till then, the next point that we have here, if you're getting a floppy child with hypertrophic obstructive cardiomyopathy, so cardiomegaly on X-ray, floppy child, hepatomegaly, Coats facies, think of Pompe disease or type 2 GSD. And enzyme replacement therapy is available for the treatment of Pompe disease, right? So very important to diagnose it. So SMA, the drug, yes, very good, Sam, Vicky. I am really impressed. So nusinersen is one of the newer drugs which are available, antisense oligonucleotide available for the treatment of spinal muscular atrophy. Okay. Now, A male child, if you're getting a male child with progressively increasing weakness of proximal muscles with Gowers sign positive, okay, that means difficulty in getting up from sitting position on the ground, Valley sign positive, pseudo hypertrophy of calf muscles, highly elevated CPK value in thousands. Think of Duchenne muscular dystrophy. And if the onset of disease is later, okay, after 5 to 7 years of age, and the disease progression is not so severe, think of Becker muscular dystrophy. And the mode of inheritance of these disorders, who will tell me the mode of inheritance of Duchenne and Becker muscular dystrophy? The mode of inheritance is X-linked recessive inheritance, right? And the drug which is recently available is eteplirsen. Again, it is an antisense oligonucleotide, a newer drug which is available for DMD. Otherwise, till now, the standard of care for children with DMD has been corticosteroids. It will not cure the disease, but it will delay the progression and make the child remain ambulatory for a longer time, right? So moving ahead, the most common surgical cause of non-bilious vomiting in infants is hypertrophic pyloric stenosis. So hypertrophic pyloric stenosis, you can get an olive-shaped palpable mass in the abdomen, upper abdomen of the baby, okay, and non-bilious vomiting can be there. But if mother has taken azithromycin during pregnancy, it is believed to be one of the risk factors for hypertrophic pyloric stenosis, and it can be easily detectable by ultrasound of the baby, right? And surgery will of course be required. The most common abdominal emergency of early childhood is intussusception. So what do you mean by intussusception? Who can tell me? So intussusception is, telescoping of one bowel segment into another. Can you tell me some radiology signs that can be seen in intussusception? Some signs that you can get on radiology on intussusception. Clinically, the baby will present with incessant episodes of crying due to the colicky abdominal pain. You can get current jelly stools, that means blood and mucus mixed stools can be there, and a sausage-shaped palpable abdominal mass can be there. Okay, and waiting for your radiology. So very good. So you can get target sign, claw sign, you can get coiled spring sign. Okay, so lots of radiology related signs are there in intussusception. Okay. Now, the best screening test for celiac disease is a combination of anti-TTG IgA and total IgA. Okay. And if this anti-TTG IgA and total IgA, if you do an anti-TTG IgA is more than 10 times the upper limit of normal, then you can do another antibody based test which is most specific. That is the anti-endomysial antibody. So anti-TTG antibody is more sensitive. Anti-endomysial antibody is more specific. So if this is also positive on a next blood sample, then you can diagnose celiac disease even without intestinal biopsy, friends. Okay. Otherwise, the standard of care has been do anti-TTG IgA. If it is positive, go ahead with upper GI endoscopy and duodenal biopsy. On duodenal biopsy, we all know in celiac disease, you will get flattening of the villi will be there, crypt hyperplasia will be there, intraepithelial lymphocytes will be there, and you do Marsh grading on the biopsy specimen, right? And a lifelong gluten-free diet is the treatment of choice. Okay, very important. N number of times you've got case scenarios on celiac disease. Don't miss it. Most common cause of intestinal obstruction in 3 months to 6 years of age, we already discussed intussusception. Treatment of acute diarrhea, again very important, we already discussed prevention and treatment of dehydration, zinc therapy and continuing normal diet. Composition of ORS, very very important. Osmolarity of ORS, reduced osmolarity of ORS, we know is 245, very important. Read up. The rickets, radiology, again very very important. Clinical features of rickets, very important. You will get calcium and phosphate which can be normal or low. Alkaline phosphatase always elevated in rickets. Most common cause is nutritional deficiency of vitamin D. Lot of clinical features are there: frontal bossing, parietal bossing, rachitic rosary, Harrison sulcus, wrist widening, pot belly, bending of bones, okay, double malleolus, right? And you can get genu valgum, verum and all that can be there. And rickets, the radiology findings are cupping. Cupping means the concavity. Fraying means the irregularity, and splaying means the widening of the ends of the long bones. Okay, and the earliest out of these to appear is the fraying. And once you start treatment, 6 weeks later, we expect radiological improvement in the form of a line of healing that begins to appear. Right? Scurvy is due to vitamin C deficiency. We all know that scurvy, vitamin C deficiency, it leads to gum bleeding, prominent costochondral junctions. Corbutic rosary is more tender, angular as compared to rachitic rosary, which is more rounded and painless. And you can get painful pseudoparalysis of limbs. What do you mean by painful pseudoparalysis of limbs? So in scurvy, there are painful subperiosteal hemorrhage involving the long bones. So much of pain that the child will not want to move the limbs. Okay, and if you touch, the child starts crying. So it is painful pseudoparalysis of the limbs. And scurvy, more chances of scurvy in those babies who are cow milk fed, because cow milk is deficient in vitamin C. The radiology features of scurvy also very important. Read up. You can get, this subperiosteal hemorrhage, dumbbell shaped subperiosteal hemorrhage. You can get Pelton spurs. You can get the Wimberger sign. So the radiology features of scurvy also very important. Treatment, of course, is vitamin C. Okay. And the last point, friends, of this 100 lines marathon session, the one liner. So juvenile idiopathic arthritis, if you're getting a case scenario where you're getting a child who is say 12 years old and having pain in 3 or 4 joints along with swelling, which has been there for 2 to 3 months, think of juvenile idiopathic arthritis. So the diagnostic criteria is arthritis of one or more joints lasting at least 6 weeks in a child less than 16 years of age. Okay, think of JIA. There are three types of JIA: polyarticular, polyarticular, and systemic onset JIA. The most common type is the polyarticular or the oligoarticular. Okay, polyarticular is the most common, and in systemic onset JIA, you can get hepatosplenomegaly and rashes and fever before the onset of arthritis as well. Right? So, friends, these are some very, very important 100 essential one-liners. So, do see this video once again in a high-speed once before your exams. Okay, and please don't make a mistake and don't skip any of the questions which come from these topics. And please, I'm sure you've worked hard. Have faith in yourself. Now is the time to consolidate things together. And remember, nothing is impossible to a willing heart. And I'm sure each and every one of you is going to crack your exams, and you're going to come out victorious. So all the very best, friends, and God bless you. Thank you.